Okay, good evening everyone. So, can everyone hear me? So, we will start with the session. This session is for first year MBBS students. How they are going to clear their first year examination. It is very important. So, myself, Dr. Mona Lisa. I am your anatomy faculty for the first year MBBS. So today's session is starting with the first topic, which is very basic to understand. So I will go in a sequential manner. Okay. So all of you can hear me. If you can hear me, you can just write it on me on the chat box. There is that you can hear me so that we can start the session. So for today's session, I am going to tell you about the general anatomy topics. So we will start with the general anatomy topic, which is a very important topic to understand anatomy in detail. So for the proper understanding of anatomy, it is important that you should understand the basics of anatomy. Okay. So it is important for you to know the basics of anatomy. So here, starting with the first session, on the DNA platform. This platform is mainly for the first year students. Yeah, very nice. Okay, welcome XYZ. Okay, so he can hear me. He or she can hear me. Nice. So we will start with the session today. Good evening to everyone who is the participant for the class. Okay. So for the today's session, we are going to cover the general anatomy topics. So before starting the topic in detail, I just want to brief you that you have to be very serious about anatomy topic. Okay, anatomy is very important for you to understand the clinical subject. Okay, it is the root of all the subject. Okay, so in the first year you have got physiology, you have got biochemistry, you have got anatomy. So if you are understanding anatomy well, then only you are able to understand the gynae, you are able to understand surgery, you are able to understand ENT, ophtha. Okay, so all the subjects are correlated. You will understand better the ortho. So it is important that you have to pay attention to the subject. The subject is carrying so many. It is carrying so many weightage. Okay, ma'am, it's me, Dev. Okay, Devraj, welcome to the class. So what is important that if you have to properly pay attention to anatomy. I'm not telling that you have not to pay attention to other subject. All the subjects are equally important. Okay, but weightage of anatomy is so much. You have to complete that whole competency. Now what is important is you have to have the knowledge of competency based study. So if you are knowing all the competency to be achieved, it is important for you to pass the first year MBBS exam. So firstly, just maintain your roots, strengthen your roots. Okay, हमारा जो roots है उसे strong होना है. It has to be strong so that you can understand better. Okay, so now the study is being integrated from this year. What you have seen that there is competency based study which is following all over the India. Okay, so you have to study in the manner that you have to complete the competency of each and every topic. So learning objective of this class. So starting with the learning objective of this class. So it is important for you to know the learning objective of this class, in which you have to know the basics of this class, in which you have to know what all things you have to be very much accomplished with it. So today's class, the learning objective. Okay. So all of you can just see the screen. Yeah. So starting with the learning objective. Okay. The learning objective of this session is to know basics of general anatomy. Okay, basics of general anatomy. So the basics of general anatomy is to know about following points. We are going into the details of skeleton, basics of skeleton, not the histology part. I will take another session in which whole of the general histology will be covered. Also the basics of muscles. Okay, the joints, very important topic. Also modification of deep fascia. Okay, so it is important for this class. In this session, I am going to cover the general aspect of skeleton, muscles, joints and modifications of deep fascia. What other important points you have to know? The other important points which I am going to cover here in this class is that you have to know about the epiphysis. Epiphysis is very important. Types of epiphysis. So you have to know all the types of epiphysis along with the example. You have to know morphological types of muscles. It is important for you to know the morphological types of muscles. So this is all the competency which you have to achieve from this class. What else you have to know? You also have to know different type of muscles. You have to know shunt muscle. You have to know sprut muscles. You have to know the types of synovial joint in detail. All the joints. It's not only the synovial joint but all the joint. Also you have to know the example of all the joints, okay, and where this joints lies. Also all the morphological type of muscles, okay. Also the parts of long bone. So without wasting much of the time, I will start with today's session, okay. So you can hear me, Devraj. So starting with today's session. So firstly, I just want to tell you about paniculus carnosus. Okay, what do you mean by the word paniculus carnosus? The first and the foremost thing is, what do you mean by paniculus carnosus? Okay, what is paniculus carnosus? Paniculus carnosus are those muscles which are lying in the cutaneous region, which is lying superficial fascia. These muscles are lying in superficial fascia. Where these muscles lies? This muscles lies in the superficial fascia. Okay. So in between I will check the chat box also. If you have any confusion, you can ask me. Okay. Let's start with the study. The paniculus carnosus is very important for the viva. So during the entire course, I will stress about the points which is important for clearing the theory exam, and along with it, I will also stress on the point which is often asked in the viva. Okay, so it's not only that your medical college professors will be the external. The external can come from all over India. Okay, it is going to be an integrated exam. So it is important that you have to achieve all the competencies. Okay. So the first and the foremost thing which is often asked in the viva, it is very important for the viva examination. What is important is to know the superficial fascia. So the muscles which is lying in the superficial fascia is called as paniculus carnosus. The example of the muscles are following. So I will give you the list of the muscles. The muscles are, write down the name. The one you can see in this diagram. So what you can see, this is corrugator cutis ani. So you must be, the next point will be, ma'am, what is corrugator cutis ani? Now, what is this corrugator cutis ani? Corrugator cutis ani is a muscle which is surrounding this corrugator cutis ani, which you can also see in the diagram. Okay, so corrugator cutis ani is the muscle which is lying around the anal margin. So see here, I will just highlight this diagram. Just see only the diagram. Can you see? This is the anal intramuscular septum, and on the lateral aspect of this, the muscle is corrugator cutis ani. So this is the muscle which is lying in the superficial fascia. Okay. So the other examples are, coming to the other examples. So other examples are following: muscles of face, scalp, ear. So these muscles, Also is very small. They are very cutaneous. Also the other examples are palmaris brevis. Which muscle? Palmaris brevis muscle. It is a superficial muscle which is lying in the palm. What you can see, this is my palm. On the medial aspect here, a small slip of muscle lies here. Okay, here a small slip of muscle lies, that is a cutaneous muscle. The name of that muscle is palmaris brevis. Also a muscle of the scrotum. So see here, this is the diagram in which, okay, can you see the black arrow? This black arrow is showing the location of palmaris brevis muscle. Which muscle? Palmaris brevis muscle. So this is another example of panniculus carnosus. Also a muscle of the scrotum lying in the scrotum. That muscle is dartos muscle. Which muscle? Dartos muscle. So this is the muscle which is lying in the scrotal area, dartos muscle. I will show you the diagram. See here. So can you appreciate this diagram? So see here we have got the muscle here. This muscle is the dartos muscle. So another example is dartos muscle. So in short, how you are going to remember the muscles which is lying in the superficial fascia, the muscles of the face, the muscles of the face. This lies in the superficial fascia. This is not bounded by deep fascia. Generally what happens, muscles is covered by a deep fascia modification. Okay, but here the muscles are lying in the superficial fascia. All the muscles in the face are superficial fascia. The muscles lying in the scrotum, that is dartos muscle. The muscle along the anal margin, that is corrugator ani, that is another example. A small muscle lying in the palm in the medial aspect. This muscle is an example, palmaris brevis. So these are the muscles which are example of the superficial muscle. Now coming to the superficial fascia. So other basic point which is often asked in the viva. So I just want you to pass the examination with super colors. Okay, so you have to just clear the examination. The first and the foremost thing is to pass the first year MBBS. If you are going to pass the first year MBBS, then only you are going to have the other examination, second year, final year, then NEET PG and all. So please make the roots strong. You have to make your roots strong. So the next viva question which is often asked is superficial fascia without any fat. In this there is no fat. So in the eyelid there is no fat. Also in the ear there is no fat. Okay. So these are the areas which is devoid of fat. Okay. These are the areas which is not containing fat. Okay. Not much of the fat is lying here. Okay. Eyelid, ear, these reasons are not, now the reasons like mammary gland, okay, gluteal regions, these are the region where they have got a fat. The other reasons are clitoris, penis, scrotum, okay. So these are all the reasons where you have got no fat. So, okay. Now, superficial fascia without fat is eyelid, ear, clitoris, penis and the scrotum. Now coming to modification of deep fascia. So what are the modification of deep fascia? It is important to know the modification of deep fascia. Modification of deep fascia is following. It will form a covering over the muscles. It is forming intermuscular septum. What it is forming? It is forming intermuscular septum. What else? It is also form a covering over the muscle fibers. That is what? It will form endomysium. It will form perimysium. It will form epimysium. Okay. So the deep fascia is these all endomysium, perimysium, epimysium. These are the coverings over the muscles. So an individual muscle fiber is covered by a covering that is called as endomysium. The whole muscle bundle, or muscle fascicula is covered by the connective tissue covering that is called as perimysium. And the entire muscle, the whole of the muscle is covered by a covering that is called as epimysium. Okay. So these are the modification. Other than that, we have got other modifications of deep fascia. The other modification of deep fascias are following. It will also form a covering over the nerves. So it will form endoneurium. What it will form? Endoneurium. It will form epineurium, perineurium, same as that of muscles. Like in the muscles also there is covering, same way the nerves, fibers and nerves will also have a covering. Other than that, deep fascia modification is it is forming interosseous membrane. If you remember, interosseous membrane is a connecting link between two bones. Like radius and ulna is connected by which membrane? Interosseous membrane. So this is another modification. Tibia, fibula also have got a membrane attaching it, that is called as interosseous membrane. Other modification will be ligaments, tendons, aponeurosis, also there will be aponeurosis. So these are all modifications of deep fascia. Okay. Now coming to the other modifications. Other modifications will be like we have got also other modifications like retinaculum. Retinaculum, if you remember, like this is the hand, here we have got, here the carpal bones are there and here we have got a fibrous band like this. This fibrous band is holding all the flexor tendons together. That is called as retinaculum. So we have got fibrous retinaculum, we have got extensor retinaculum, also we have got fibrous capsules. This capsule, fibrous capsule, also the capsules of organs, these are all modifications of deep fascia. So these are the basically modifications of deep fascia which is important for you to know. This is often asked in the examination. Okay. So it is very important for you to know that. Okay. Now coming to skeleton. Okay, so starting with the skeleton, it is a red color and blue color. Can you see there is a red color things marked in the skeletal body and there is a blue color thing which is marked in the skeleton body. So what do you mean by axial skeleton and what do you mean by appendicular skeleton? These are very basic but often asked. So what you have to tell, if this question is asked in the Viva, just reply like this, that what you can say here, that axial skeletons are the skeleton which is lying in the midline. Can you see the blue color structure which is shown are all the structures which is lying in the midline. There is skull, there is vertebral column, there is ribs, and the pink color thing which you are seeing, these are the appendicular. These are appendicular skeletal lower limb bones, upper limb bones. So altogether we have got 80 axial skeleton and we have got 126 appendicular skeleton. Okay, so we have got 126 appendicular skeleton and we have got 80 of the axial skeleton. So altogether how much? It is 206. Now generally the whole number of bones are 206, but it can vary also. It is not like if you count the bone of children's, the fusion is at not completed and therefore there will be more numbers of bones. Now coming with the topic of parts of bone, it is very important to know the parts of bone. Okay, so here this is a diagram which is showing the parts of the growing bone. So I will mark you the parts of the growing bone. The ends of the bones are called as, epiphysis. Okay. So on both the ends, this is which part of the bone? This is the epiphysis part of the bone. Okay. The middle part or the strongest part, is the diaphysis. This is the diaphysis. Okay. Also the ends here, this part with the epiphyseal end of the diaphysis which is going towards the end, this part is called as metaphysis. This part is called as metaphysis. Okay. And the plate of bone which you are seeing, coming to this plate of bone, can you see on either side there is a encircled, I have encircled this part, that is called as the plate of bone. This plate of bone is called as epiphyseal plate of bone or epiphyseal plate. EP for epiphyseal plate. Okay, so generally epiphyseal plate become fused, the epiphysis and that of the diaphysis all become fused in the adults, and when the bone is in the growing part, this is not fused. Okay, these are the parts of the bone. So how you are knowing? The epiphysis is the ends of the bone. Okay, as you can see, these are the ends of the bone. Metaphysis is the part of the bone which is epiphyseal end, and the middle and the strongest part of the long bone is called as diaphysis. Now again, certain more points about this. So you just know diaphysis is mainly formed by the shaft. It is formed by the shaft of long bone. It is formed by the shaft of long bone. It is strongest part of the bone. Now, what is the basic feature of metaphysis? Now, metaphysis is very vascular. Okay. One of the clinical aspects which is related with this topic, I will explain you that generally asked in the Viva question that which is the reason where there is more of osteomyelitis. Okay. So, which is the reason which is more affected by osteomyelitis? The answer will be metaphysis. Now, why? Why very important? It's a very important for Viva question that why metaphysis is an important reason where we have got osteomyelitis. Now what happens in the metaphysis? There is vascular loop or capillary beds. Okay, so many anastomosis is there. In the metaphysis region, there is anastomosis of the blood vessels. There is anastomosis of metaphyseal artery. There is anastomosis of epiphyseal arteries. Okay. Also the branches of nutrient artery. So they will form a capillary hairpin bend, okay, at the metaphysis region, and therefore if there is any thrombi, if there is any bacteria in that, that will get trapped in that of hairpin bone. That will get trapped in that of hairpin bend area, and so metaphysis becomes the area of maximum osteomyelitis cases. Now, so most commonly, which part of the long bone is affected in osteomyelitis? The answer will be metaphysis. Now, this part which you are seeing, that is the epiphyseal plate, is generally in the developing part of the bone, not fused, but ultimately it will fuse and just form an epiphyseal line. So I will show you in another diagram. See, this is the parts of the long bone. Can you see the diagram? Okay, this is showing the parts of the long bone. So this is the shaft part. What is it? It is the diaphysis. Now, can you see the line here? At either end, there is an orange color line, which I have marked here red. That is epiphyseal end. That is because of the fusion of epiphysis and diaphysis. The epiphyseal plate is transformed into epiphyseal line. This is the upper end of epiphysis, this is the lower end of the epiphysis, and close to it lies the metaphysis. So we have done with the parts of the long bone. Now coming to type of epiphysis. Very important. This is very important for Viva and also for the theory examination. So what is important? For the theory paper, you have to know it. So you have to know this for the theory paper and also for the Viva, for both parts. So it is important for you to know the types of epiphysis and also you have to know the example of epiphysis. So coming to this diagram, let me just enlarge this diagram. Okay, so what you can see here, that there is 4 types of epiphysis. Atavistic epiphysis, as you can see, there is aberrant epiphysis, there is pressure epiphysis, and there is traction epiphysis. So how many? Pressure epiphysis, traction epiphysis, atavistic, and the 4th is aberrant epiphysis. So how many epiphysis we have got? We have got 4 epiphysis: aberrant, traction, atavistic, and that of pressure epiphysis. So one by one I am going to explain each of it, and there itself I will give the explanation of it along with the example. So starting with the first, that is pressure epiphysis. So starting with the first, that is pressure epiphysis. Okay. Yeah. So starting with the first, that is pressure epiphysis. Now what do you mean by pressure epiphysis? Where is the pressure epiphysis will lie? Pressure epiphysis will lie at the articular joint end. So wherever the bone is forming an end or articular part where it is forming a joint complex, if the parts of bone which forms the joint are example of pressure epiphysis, okay. So they are mainly involved for what? They are mainly involved for weight transmission. weight transmission. So whichever part of the bone which is involved for the weight transmission, that forms the pressure epiphysis. So example of these type of epiphysis will be, write down examples. So I just want to rub this, then I will give you the example of pressure epiphysis. So it's if you are understanding the point, you can only give me the examples. Example of pressure epiphysis will be that part of the bone which are involved in forming the joint. So that will be head of femur, condyles of femur, condyles of tibia, okay, also head of humerus. So all these parts are example of pressure epiphysis which is involved in forming the joints. Now coming to the second one, that is traction epiphysis. Now this traction epiphysis are formed because of, the traction epiphysis are generally, these traction epiphysis are formed due to the pull of muscles. So these are formed because of pull of muscles. They are formed due to the pull of muscles. Okay. The example will be following. So starting with the example. Epicondyles. Okay. So the condyles are example of pressure, but epicondyles. So we have got medial epicondyles. We have got lateral epicondyles, both in the humerus and that of femur. So humerus, femur, you can say mainly the femur and all, these are involved for the traction epiphysis. Okay. Also other example will be tubercles. Tubercles of humerus. So that is greater tubercle and lesser tubercle. So these are all examples of traction epiphysis which is formed due to the pull of muscles and tendon, but they are not taking part in formation of joint. Okay. Now coming to atavistic epiphysis. The next which we are going to study is the atavistic epiphysis. Okay. So atavistic epiphysis means if you will take the example of, for example, if you take the example of animals' bone, they are present, but in case of human beings, in case of ours, these are actually example of the bones which are the part of some other bones which have fused with the one bone. For example, we have got two examples in this case. One is posterior tubercle of talus. Posterior tubercle of talus is also called as os trigonum. It is also called as os trigonum. The second example is coracoid process of scapula. So here you can see this is coracoid process of scapula and this is the posterior tubercle of talus. So these are the example of atavistic epiphysis, okay, which is originally a part of different bone but has fused with this bone. So in human beings they are a part of, like for example, coracoid process is the part of scapula bone, but the tubercle, the posterior tubercle is a part of talus bone, but in case of animals still they are a separate bone. So understand atavistic epiphysis. Now coming to aberrant. All of you, anyone has any doubt, they can ask me in the box. They can just type there in the chat box and I will see and I will explain once more. Don't worry about it. Now, aberrant epiphysis means they are not at the correct location. They should have to be another location, but they are aberrant in the location. So the example is aberrant epiphysis is present at the head of first metacarpal. Aberrant epiphysis is present at the head of first metacarpal and base of other metacarpals. Aberrant epiphysis is present at the head of first metacarpal and it is present at the base of other metacarpals. Now coming to the blood supply of long bone. So next important thing is the blood supply of long bone. So it is important for us to know the blood supply, which is often asked. So the major blood supply is from nutrient artery. Which artery? Nutrient artery. I will also write the name. Also the supply is from epiphyseal artery. Metaphyseal artery, and also there is perosteal arteries. Okay, so four basic source: nutrient artery, epiphyseal artery, metaphyseal artery, and that of perosteal artery. These are the four sources of arterial supply or blood supply to the long bone. Okay, so it is important for you to know the basic important points about these arterial supply, which is again asked as an viva question, and also it can come for the theory examination. Okay, so now if any query is there, any question is there, you can ask your doubts. Now coming to the blood supply. Okay, so again I just want to tell you that nutrient artery. Now nutrient artery is the artery which is entering in the bone from which foramen? From the nutrient foramen. From nutrient foramen. So these will enter in the bone from the nutrient foramen, and thereafter it will go in upward and lower direction in the form of ascending and descending branches. So it will supply, what is important, that nutrient artery will supply which part of the bone? It will supply inner 2/3 of compact bone. It will supply inner 2/3 of compact bone. Okay, nutrient artery. So about other arteries, now I will explain about other arteries. Now this was all about nutrient artery. Now coming to metaphyseal artery. Metaphyseal artery is generally the branch of neighboring arteries, and this is giving mainly blood supply to epiphysis and that of diaphysis. So it is giving blood supply to which all part? It is giving blood supply to epiphysis and that of diaphysis. Other than that, there is epiphyseal arteries. This epiphyseal arteries are generally branch of arterial anastomosis. Arterial anastomosis. Debraj, are you understanding? Okay. Let me just check. Okay, so epiphyseal artery is the giving mainly a branch from arterial anastomosis, and it will mainly supply the articular capsule. It will mainly supply articular capsule. The perosteal artery, one more artery is the perosteal. So just here itself I will write. One more artery is perosteal. Perosteal arteries, these are mainly supplying outer 1/3 part of compact bone. Inner 1/3 part of compact bone was getting arterial supply from nutrient artery, but outer part of the compact bone is getting supply of blood from the perosteal artery. So we have done with this. Now coming again to the another topic, morphological classification of the bone. So it is important for us to know the morphological classification. It is very basic. You must be knowing that we have got different types of bone. We have got long bones. Femurs, tibia. We have got short long bones. Short long bones mean phalanges, metacarpals, metatarsals. We have got also irregular bones. Irregular bones means that of hip bones. We have got flat bones, bones of the skull. They are flat bones. We have got sesamoid bone. So we have got sesamoid bone. We have got I will explain sesamoid bone. It is very important. Again, it is important for viva and also for short note. SN for short note. So in the theory paper, you can get a short note on sesamoid bone. So I will explain the sesamoid bone in detail. Also, the other type of bone is pneumatic bone. Pneumatic bone means the bones which is having air inside. Okay, pneumatic bone. So now coming to the first group which I will explain you is the pneumatic bone. So can you see in the screen the pneumatic bone? So it is important for you to understand which all bones are pneumatic bone. Okay. So the pneumatic bones means the bones which is having air inside. Okay. So these bones are generally the bones like having air sinuses. So we have got different bones which has got air sinuses inside. Okay. You can hear me, all of you? Okay, so it is having air sinuses inside. Okay, so we have got frontal bone. Frontal bone will have frontal air sinus inside. As you can see in the diagram, we have got ethmoidal sinuses. Ethmoidal sinuses will be in the ethmoid bone. Okay. Also the maxillary bone, which is an example of maxillary bone, will have maxillary sinus inside. So it is an example. We have got sphenoid bone. Another example will be sphenoid bone. So sphenoid bone will have sphenoidal sinus inside. So this is another example. So you can see on one side I have marked all the sinuses. So the sinuses which are contained inside the bone, that forms an example of pneumatic bone. What is the role of pneumatic bone? It is making our skull lighter. Okay. So this is the skull, and this skull has to lie on the top of the body. So if these bones are very heavy, what will happen? We will carry so much weight on our head. So this is not good. So what is there? For example, on the other side, you are seeing one bone in which the maxillary air sinus has been sewn. So you can see this part is the maxillary air sinus, which has got air trapped inside, and this will make the bone lighter in weight. So other class of the bone which I am going to describe you is the sesamoid bone. Okay. Now this sesamoid bone is not a true bone. It is not a true bone. So why not a true bone? This sesamoid bone is not a true bone. The reason is that it is not a true bone because it develops inside tendons of muscles. It develops inside the tendons of the muscles. It develops inside the tendons of the muscle. So it is not a pure bone. It is devoid of periosteum. So I will also take a class in which I will describe the bone histology. So what you are knowing, the bone has got an outer covering which is called as periosteum. The bone has got an inner covering which is called as endosteum. Okay. So sesamoid bone is not having an outer covering, so it is devoid of these covering, that is periosteum. It is important to know the features of sesamoid bone. So at certain places we have got sesamoid bone. So starting with this, so in this diagram you can see one of the largest sesamoid bone in our body. The largest sesamoid bone in our body is patella bone. So the patella bone is the largest sesamoid bone in our body. Patella bone is the largest sesamoid bone in our body. It is the largest sesamoid bone. Okay. And another you can say MCQ or the Viva question which is very important, which is often asked in the Viva, is patella bone is originating, it is developed in which muscle? The answer will be it will develop in quadriceps femoris muscle. Which muscle? Quadriceps femoris muscle. What I told you, very important for you to know. So I am marking it star point. You have also to know the important bones which is developing, important sesamoid bone which is developing in the muscle tendon. So the answer will be the sesamoid bone. Which sesamoid bone? The patella bone. Here we can see this is the patella bone which is lying on the anterior aspect of knee joint. It develops in the tendon of quadriceps femoris muscle. Where it develops? It develops in the tendon of quadriceps femoris muscle. So see this. This is a radiological image which is shown in the diagram. As you can see, this red arrow. Can you appreciate this red arrow? So this red arrow is showing a small bone here. Can you see this small bone? This small bone is another example of sesamoid bone. So this bone is the fibula bone. Which bone? It is fibula bone. This bone is a fibula bone, and this has been developed in the tendon of lateral head of gastrocnemius muscle. Lateral head of gastrocnemius muscle. It has developed in the lateral head of gastrocnemius muscle. Okay. On anterior aspect, can you see this? This is which bone? This is patella bone. This is patella bone. Okay. So this is patella bone and this is fibula bone. Two sesamoid bone we have seen. One is the fibula, other is the patella bone. Now seeing the another example of sesamoid bone which will be shown in the diagram, as you can see, the red color bone which is highlighted here, this is the pisiform bone. So my dear students, the pisiform bone you have seen, it is the smallest carpal bone. It is a smallest carpal bone. It is the smallest carpal bone, and this is again a bone which has developed in the tendon of which muscle? FCU. I have written in short form. What is FCU? Flexor carpi ulnaris. What is it? It is flexor carpi ulnaris. It is flexor carpi ulnaris. So the spiciform bone is another example of sesamoid bone which is originating in flexor carpi ulnari, which is formed in which muscle tendon? Flexor carpi ulnaris. Okay. So let's see the other example of sesamoid bone in the diagram, as you can see. So this is the sesamoid bone which you are seeing. This two sesamoid bones here is. These sesamoid bones are developing in the tendon of peroneus longus muscle. So the other name, this is peroneus longus muscle, is a muscle which is lying in the lateral compartment of the leg. There is peroneus longus and peroneus brevis, and peroneus longus muscle there is development of two sesamoid bone. Also you can see here, this is the another sesamoid bone location. These are flexor hallucis brevis. Okay. Hallucis means great toe. So flexor hallucis brevis is giving another example of the sesamoid bone. Flexor hallucis brevis. Okay. See in the diagram, you can see from the posterior aspect, plantar aspect of the sole, you can see the sole here. There is location of two small bones, and these two small bones are developing in the tendon of which muscle? Flexor hallucis brevis. So my dear students, see this diagram. Okay, can you see this diagram? These are the sesamoid bones which is found in the finger. So it is very important for you to know the location of sesamoid bones in the finger. So you can see here the sesamoid bones location. So here there can be 99 to 100% chance of forming a sesamoid bone in the metacarpophalangeal joint of the thumb. So metacarpophalangeal joint. Metacarpophalangeal joint. So we can write in short form MCP, which first metacarpophalangeal joint, that is the thumb, there is chance of 99% presence of sesamoid bone. There is chance of 99% of sesamoid bone. So it is important for you. Generally there is an exam, there is radiology also, which is in the first year MBBS you have to give exam on the viva on the radiology part. So the basic question this is asked in the viva is the location of sesamoid bone. So all other location I have already explained. Other than that, you have to tell that metacarpophalangeal joint of the first thumb is 99% there is chance of presence of sesamoid bone. Other than that, the other metacarpophalangeal joint has got a presence of 40 to 60%. So there can be 40 to 60% of the chance where you can find the location of the other sesamoid bones. Okay. Now, types of ossification. So, what is this? Types of ossification. So, generally there is two types of ossification. One is called as enchondral ossification. Other is called as intramembranous ossification. So, the basic difference between the two is important. You should know the basic difference between two. So, enchondral ossification means the ossification which is occurring from the bone is formed from the cartilage. So what happens? Firstly, a cartilage is formed, and this cartilage is further transformed into mature bone. So then the bone is formed. So most of the bone in our body is going through which type of ossification? Enchondral ossification. The other type of the bone formation technique is intramembranous, where the bone is directly forming from the mesoderm or mesenchymal tissue. They are directly developing from the mesenchymal tissue. There is no formation of cartilage. This type of ossification is called as intramembranous ossification. So it is important for you to know which bone goes for the intramembranous ossification, which bone goes for the membranous ossification. So for enchondral ossification, most bones will have enchondral ossification. All the long bones in our body will form enchondral ossification. Intramembranous ossification. The intramembranous ossification is seen in sphenoid bones, is seen in occipital bone. Okay, these are the bones. It is also seen in the clavicle bone. It is also seen in the part of the mandible bones. So temporal bones. So these are the bones where you can see mainly the membranous ossification seen in the skull bone. Now I would like to tell you the name of the bone where both intramembranous and that of enchondral ossification goes. So write on this. Both intramembranous plus enchondral ossification. So there is both enchondral ossification going on and there is going on intramembranous ossification. So these type of bones are clavicle bone. Okay. So in clavicle bone, in the mandible bone. Okay. So mainly the clavicle mandible bones are the bones where both types of enchondral and that of intramembranous ossification is going to take place. Both type of the ossification is going. Okay. So now coming to ossification. Okay, so it is important for you to know the ossification. So what is important that we have got primary ossification center, we have got secondary ossification center. Now what happens in the location of diaphysis, that is the shaft. What is this? This is the diaphysis. Okay, so this is the diaphysis which you can see. This is the diaphysis. So in the region of diaphysis there is appearance of which type of ossification? Primary ossification. Primary ossification. क्या होता है वहां पे? The region where there is diaphysis, there is primary ossification, and primary ossification centers appears before birth. They will appear, primary ossification centers appears before birth. Okay. Secondary ossification center. Secondary ossification centers appears after birth. Secondary ossification centers appears after birth and that of primary ossification centers appears before birth. Okay. Secondary ossification centers appears at the ends of bone. They appears at the ends of bone. It is important that they appears at the ends of the bone. So what is the role of secondary ossification center? The growth of the bone. So once the secondary ossification centers appear and it is fused, further growth of bone doesn't happen. Further growth of bone is not possible. Now one of the basic point is that you have got so many advertisements going on in the TVs and all the online shopping things that there is certain medicine which you will take and your height is increased. Okay, so if you are a student of anatomy, you have known that the secondary ossification center once fused, the further growth of the bone is not possible. So it is the basic thing that all advertisements and all are wrong if once your ossification centers, secondary ossification centers has been fused, and then there will be further no increase in the height. Okay, so generally the fusion of secondary ossification centers appears 2 to 3 years prior in case of females. In case of females, the ossification centers fuses, secondary ossification centers fuses earlier than that of the males, and therefore this is the reason that the females has got shorter height than in comparison to the males. Their height is shorter. This is the reason. So all that advertisement, please don't believe that advertisement. It is all wrong. Okay. Now coming to ossification, further detailing about the ossification. So the further important point is that you should in general know that primary ossification center appears, primary ossification centers appears before birth, and generally the general time is 6th to 7th or 8th week of intrauterine life. Only clavicle is the bone in which this is exception. What is exception? That in clavicle the primary ossification centers appears by 5th week of intrauterine life. So only we tell that the first bone to ossification to appear is the clavicle bone. Okay. So generally this primary ossification centers appear before birth, and generally as a rule 6th to 7th or 7th to 8th week of intrauterine life. But in case of clavicle, that appearance is earlier in case of the clavicle. So it is important to know this. The other important point is that in case of certain bone, so you should know this point. I will just tell you about this point. Write on this point. In case of navicular bone, and cuneiform bones. So how many cuneiform bones we have got? We have got lateral, we have got medial, and we have got intermediate cuneiform bones. Okay, so we have got lateral, intermediate, and medial cuneiform bones. All these bones, primary center of ossification appears, all these bones, the primary center of ossification appears after birth. So it is not forming the rule here, their ossification centers are appearing after birth. Okay, so this is important. Other than that, I would also tell you about the other examples. So as what I told you, that secondary center of ossification. What I told you, secondary center of ossification appears after birth. It appears after birth. But in case of lower end of femur, and upper end of tibia, the secondary centers appear. The secondary center appears before birth. So generally just before birth, that is 9th month of intrauterine life, you can say just the 9th month of intrauterine life, it is appearing just before birth, not after the birth. Okay, so this is an exception here what you have seen. Now coming to again the other details, we will talk about the other details. Okay, direction of nutrient foramen. So it is very important for you to know the direction of nutrient foramen. Okay, direction of nutrient foramen is important. You have to know about this. Now, can you see the blue color lines? So these are the blue color lines which are shown in the diagram. Direction of nutrient foramen is just opposite to the growing end. So you must have seen, you can see here, there is one dot here, there is one dot here. So these dots, this is a bone, this is a humerus bone which you are seeing in the diagram. This is which bone? This is a humerus bone. Okay, this is a long bone and the direction is, as you can see, the direction is in the lower end. Okay, so the growing end, it is very important for you to know that growing end is directed opposite to nutrient foramen direction. So it is important for you to know that growing end is always opposite to the nutrient foramen direction. Okay, so you can see in this diagram that the growing end is directed to the lower end. So which will be that you will see nutrient foramen is directed to the lower end. So this upper end will be the growing end. This will be the growing end. So it is important for you to know that the growing end is the upper end. So see here, this is the law of ossification. So it is important for you to know the law of ossification. So can you see this diagram? Okay, if you are seeing in the diagram, in this diagram, yellow color lines has been shown. As you can see here, let me just mark it with red color line also. So see here, this is the direction of the nutrient foramen. So according to the law of ossification, growing end will be opposite to the direction of nutrient foramen. Growing end will be opposite to the direction of nutrient foramen. So see in this diagram, so it is going towards the elbow. What is the direction? It is going towards the elbow and it is flying away from the knee. So remember, like towards the elbow. So what is that? Towards the elbow. Okay, I go from the knee, I fly. Okay, what is the mnemonic to know that towards the elbow I am going, and from the knee I am flying. So this is the direction of the nutrient foramen. So in the case of upper end or upper limb, what is the growing end? The growing end will be the shoulder. So the growing end will be the upper end of humerus. Upper end of the humerus is the growing end, and here the lower end of radius and ulna is the growing end. Okay, now again see this diagram. Okay, so here what you can see that the arrows are directed towards, the arrow is directed here, that where is the direction of the arrow? The direction of the arrow is towards hip joint. Okay, here the direction is towards the lower end of tibia and fibula. So just reply me, what is the growing end? So here the growing end will be, the growing end in the lower limb will be lower end of femur and upper end of tibia. So just you have to remember the direction of that of the nutrient foramen. With this diagram you can see that the direction, you can say that towards the elbow I go and from the knee I fly. This is the direction of nutrient foramen. Just opposite to this will be the direction of the growing end of the bone. So with this we have finished one of the very important topic, that is modification of the fascia, dysphagia we have done. Also we have seen about the bones. Okay, so any doubt you can ask me, and after this we will again have a discussion on muscles and joints. So with this basic of the skeleton, basic important point which is often asked is covered. One of the important point I will tell you here, just let me rub this. So which bone is not following law of ossification? So the bone which is violating the law of ossification, write down. The bone which is violating the law of ossification means this is not obeying the law of ossification. So that bone is fibula. That bone is fibula. So fibula bone is not following the law of ossification. It is not following the law of ossification. It is violating the law of ossification. Okay. So what happens in case of fibula? The lower end centers, ossification centers, secondary ossification center, SO for secondary ossification centers, appear first and also fuses late. Okay, so one of the important point about law of ossification is that was the point to identify the ossification. But in one line if you will tell, the ossification centers which appear first will ossify late. So you have to write this law. Okay, so that was the nutrient foramen direction which I have explained. It was for understanding the law of ossification. But in one line, if you want to tell about law of ossification, you have to tell like this. The secondary center, write down the law of ossification. The secondary centers or the ossification centers, the secondary ossification centers which appear first will ossify last. Okay, means that will become the growing end. Okay, so the law of ossification states that the secondary centers which appear first. Okay, so it is appearing first, that doesn't mean that it will fuse first. The fusion will be late and that becomes the growing end. Other important point in correlation to law of ossification is that in correlation, it's not that the direction of nutrient foramen, that the growing end is always opposite to the direction of nutrient foramen. So it is important for you to know which is the growing end in the bone. Whenever we take a osteology part, when we study the bone, it is important for you to know which is the growing end. And generally you will find a nutrient foramen, you find a nutrient foramen in the long bone, and the growing end is just opposite to the direction of nutrient foramen. And the center of ossification that appears to be first will ossify limb. So these 2 points are very important to know, and the fibula is the bone which is not obeying this law, and there is primary ossification centers appear before birth, but in certain bones like navicular and cuneiforms they appear after birth, and secondary ossification appears after birth, but in case of lower end of the femur, upper end of tibia, it appears along with birth or just before the birth it will appear. Okay, so this is all about the bones which we have done. After that, I will come to the explanation of muscles and joint in brief. So I will give you a small break. Okay, then we can start with the joints. So we will take a small break. Okay, and then again we will resume. So let's see the time. It's like 9 o'clock. So we will resume. Let's take a 5 minutes break. Resume at 9:05 p.m. Okay, so we are resuming at 5 minutes break. So we will resume at 9 to 5 p.m. Okay, keep studying, drink water, and then again we will start in 5 minutes. Okay.
ट्रायल नहीं कर सकते सर। अच्छा इसके
Now again, just resuming the class. It's 9:05 and then we have to resume it. Now we have covered already the bones. Now coming to the joints, very important, so important for the theory. You can get long question on the joints. It's very important, all the types of the joint. It is important to understand the joints type, and also it is important to understand the example of each one of it. So starting with the class, all of you can hear me? So can I start? So you can reply or ask any doubt if you want, and you can just write that doubt in the chat box, and then we can again continue with the session. Okay. So functional classification of the joint. Okay. So now starting with the joints. So functional, if I talk about the functional aspect of the joint, there is three types of joints: synarthrosis, amphiarthrosis, diarthrosis. Three types of joint is there: synarthrosis, amphiarthrosis, and diarthrosis. Okay, here the synarthrosis is the joint. Here the synarthrosis is the joint where there is like no movements. No movements are there. Amphi is both movements are, slight movements are there, slight, both types, slightly movable, and it is mobile. It is a mobile joint. Freely mobile joint is the diarthrosis. So diarthrosis is a freely mobile joint. It is a freely mobile joint. Okay. So yes, they can hear me. Okay. Okay. Can you please explain aberrant epiphysis? Yes, sure. Why not? Just see. So one of the doubt is there. So let me explain the doubt and then we can proceed. Yeah. Aberrant epiphysis means abnormal position. Okay. Aberrant epiphysis means abnormal position. Okay. So my dear students, I am not knowing your name, but I will tell you the exact meaning. So it's he has a doubt. What do you mean by aberrant epiphysis? Now generally epiphysis is at how many ends? Both the ends in the long bone. Okay. So, okay, the question is, he is not understanding aberrant epiphysis. Okay, so I will explain him about, now epiphysis is present in long bone. So epiphysis, for example, if I am drawing a diagram for the long bone like this. So, okay, so epiphysis will be here also, epiphysis will be here also. Okay, okay. So what happens? These bones are lying on both the ends. What you are seeing, these bones are lying on both the ends. Okay. So these bones are, I am explaining aberrant epiphysis. I will come to your doubt, don't worry. Okay. So what happens? These epiphyses on the long bones are at the two ends. But in case of short bones, long bones. In case of long bones, it is only at one end. So generally epiphysis should not be at this location, at the head of first metacarpal, but it is wrong. It should not be here, but it is aberrant in position. Okay, in general aspect it has to be on the base of the first metacarpal, but it is at the head of first metacarpal. So this becomes an example of aberrant epiphysis, means the location is aberrant. Okay, the location is aberrant. Okay, Mehdi Hassan ma'am, why growing end is situated opposite to the nutrient foramen? Okay, now growing end is opposite to the nutrient foramen because what happens, it is the reason is that whenever we take into the consideration of the growing end, that fusion of the epiphysis becomes later. Okay, more nutrient is going at that end, so the fusion when it get time and the fusion occurs later. Okay, so it becomes late. Okay, now nutrient foramen is the foramen from which artery enters, the artery which is giving nutrition and blood. Okay, so if it directed into that end, means it is giving ample of blood, so very good nutrition, so the process will occur in a systematic faster manner, so the growing will be more at the other end. Okay, so that fusion is later. Okay, and also my dear, it also depends on the epiphysis generally. Okay, one more thing I want to explain you. Who is the person? Okay, Mehdi Hassan, generally what happens, this pressure epiphysis will fuse later. Okay, so another, it is not only that point, the other point which is correlated to it is that pressure epiphysis will fuse later. Okay, this is the reason. And after that, the other thing is that aberrant, you are knowing Newton foramen, you are knowing skull bones. Yeah, skull bones, the flat bones, that is the parietal bones, the temporal bones. So, okay, parietal bones. So, you can write parietal bones, also the temporal bones, also the parietal bones, temporal bones. These are all flat bones, sphenoid bones. Okay. So these are all bones which will have that of membranous ossification. Also the part of occipital bone, all these flat bone. Our skull is covered by the flat bone. This will all have membranous ossification. Okay. Okay. Frontal bone, all these bones. Okay. These bones, parietal, frontal, temporal, sphenoid, all will have intramembranous ossification. Now coming to the joints. So now starting with the today's session, that is joint. Classification of the joint. So after that, coming to the classification. So basically we have got fibrous joint, we have got cartilaginous joint, we have got synovial joint. Okay, so fibrous joints are generally immobile joint. Immobile joint. Cartilaginous joints are slightly mobile. It is slightly mobile. Cartilaginous joints are slightly mobile. Synovial joints are highly mobile. That is highly mobile. It is highly mobile. Okay. Synovial joints are highly mobile. Okay. So now coming to this. So can I proceed with the joints? All of you are listening. Can I proceed with the joint? Okay. Can I proceed? I am just your messages. So we should finish the joints also. It is very important today. Okay. So aberrant epiphysis because abnormal position. Okay. So abnormal position is that of the head of first metacarpal. Skull bones which intramembranously is the flat bone, that is the parietal bone, that is the frontal bone, that is the temporal bone. All these has intramembranous ossification, also part of sphenoid bone. Actually there is coalescing of both cartilaginous and membranous. So if it is asked in the viva, just explain, ma'am, flat bones of the skull has got intramembranous ossification. Okay. Also the maxilla bone on growing end is opposite to the Newton foramen. This also depends Mehdi on the pressure epiphysis. So pressure epiphysis के भी reason के कारण growing end depend करता है. Okay. Now coming to the other joints. So starting with the fibrous joint. So can I proceed? Okay. Sutures, syndesmosis, gomphosis. Okay. There is mainly suture type. There is also syndesmosis. There is also gomphosis. Okay. There is also gomphosis. Okay. Now one by one I will explain. So starting with the suture. Now in the suture what happens? Sutures are not movable. Sutures are generally not mobile. They are not so mobile, the sutures. Why? Because there is only which ligament? Inside there will be sutural ligament. Okay. So there is sutural ligament. So we have got many types of the sutures. Okay. We have got serrated suture. We have got squamous suture. We have got plain suture. So in this diagram, can you see this is the line where we have got plain suture. So the bone which you are seeing is the maxilla, and you can see the suture between palatine process of maxilla. The suture between palatine process of maxilla is an example of the palatine process of maxilla. This is an example of which type of suture? Plain type of suture. Plain type of suture. Joint is a very important topic, often comes for long question. Type of joint. It is important for you to know the type of joint. So this is an example of plain type. So can you see everyone? The red color structure which is highlighted here is an example of serrated suture. This is an example of serrated suture. Okay, so you can see very zigzag. The connection between the bones are zigzag, and you can see the suture which is lying between. Which bone is this? PP, parietal bone. Which bone is this? F, Which bone is on the posterior aspect? O means occipital bone. The suture which is connecting the two parietal bone is called as sagittal suture. Sagittal suture is an example of serrated suture. Also, coronal suture is an example of, you can see the parietal bone and that of frontal bone is connected by this suture. This suture is C, or you can say coronal suture. This is an example of serrated suture. Now see in the diagram, this suture is squamous suture. This is squamous suture. Example, squamous suture. Now this bone is parietal bone, this bone is temporal bone. Okay, so you can see connection between parietal and temporal bone. Can you see here? This connection is squamous. This connection is which example? It is of squamous type of suture. This is an squamous type of suture. This is squamous type of suture. Example of squamous type of suture. Now coming to synderesis. Synderesis, it is often asked as a viva question. Example of synderesis. So when you have you seen the base of the skull from the dorsal aspect? Have you seen the base of the skull from dorsal aspect? Okay. Okay, I will tomorrow I will try to show you the bone also. There is synderesis locator. So this is connection between, as you can see, there is connection between rostrum sphenoid and the ala of vomer. Okay, there is, you can see, when you will see the base of the bone, there is two bones which is connecting with each other. One is the vomer bone. So connection between vomer and that of sphenoid bone, this becomes an example of synderesis. This becomes an example of synderesis. Synderesis. Okay. Syndesmosis. So next is syndesmosis. So it is important for you to know what is syndesmosis. Okay. Syndesmosis. Now in case of syndesmosis, there is attachment of introosseous ligament. Which ligament? Introosseous ligament. So it very slight movement is possible. Like in suture, no movement, but here very slight movement is possible. And the example is inferior. Example, it is important for you to know the example. Example is inferior tibiofibular joint. Inferior tibiofibular joint. Also example is if sacroiliac joint. Sacroiliac joint. The articulation between sacrum and ilium, that is sacroiliac joint. Which part? It is important. Not the whole of sacroiliac joint is an example of syndesmosis. The posterior part of sacroiliac joint is an example of syndesmosis. Posterior part of sacroiliac joint is an example of syndesmosis. Understand? Okay. Other example is ligamentum flabum. This ligamentum flabum is connecting the spines. Okay, you have seen the vertebrae. In the vertebra, there is a posterior projection that is called as the spine. So, connection between the spine is formed by ligamentum flabum, which is again an example of syndesmosis. Which is an example of syndesmosis. Okay, so where the two joint is connected by introosseous ligament, that is the example of syndesmosis. We have got inferior tibiofibular joint, we have got sacroiliac joint, we have got posterior part of sacroiliac joint, and we have got ligamentum flabum. Now coming to the other example, the other type of joint that is called as gomphosis. In case of gomphosis, this is found in tooth sockets. This type of joint is found in tooth socket. This type of joint is found in tooth socket, and here it is surrounded by periodontal ligament. It is surrounded by periodontal ligament. The connecting ligament is periodontal ligament. Example is tooth socket. As you can see in the diagram here, this is the tooth socket where we have got the ligament connecting it is the periodontal ligament. Now we have done with this. The next category which we are going to see is the cartilaginous joint. So we have got two type of cartilaginous joint. One is called as primary, other is called as secondary cartilaginous joint. So we have got two types. One is called as primary and other is called secondary cartilaginous joint. Okay. So in primary cartilaginous joint, what will happen? The connecting link is of hyaline cartilage. Okay, I will take a general histology class in which I will explain the cartilage and I will give you the crux point to identify in the diagram in the case of Histology. Okay, all of you must be finding histology difficult, most of you. Just reply, histology difficult lagta hai? You are able to identify all the slides or not? So you are able to identify the epithelium or not? Tell me. Okay. So actually what happens, it is important to know the cardinal points by which you are going to identify the histological slide in the examination. So I will explain about the cardinal points also. I will tell you all the important cardinal points which is required for the identification of histological slide, which is very important point. So I will take a class on cartilage of also, don't worry about it. Hyaline cartilage, the second type of joint is that of fibrocartilage. Means what happens, generally the two bones are connected by a plate of hyaline cartilage, but in between, if it has got a fibrocartilaginous rim, means there is hyaline cartilage, and these two hyaline cartilages are again connected by a fibrocartilaginous ring, that is called as, okay. So some are telling they are finding histology difficult. Some are telling no, they find it very easy. Okay. Okay. So don't worry, we will have a histology session also. We will go further in the sequential manner. Don't worry. So what happens? I will tell you the crux point to identify the slide. Don't worry. Okay. So here, if the two joints has got in between that fibrocartilage rim, it becomes an example of secondary cartilaginous joint. Okay. So starting with the other name of primary cartilaginous joint is synchondrosis. My dear students, please know this point, that is synchondrosis is the other name for, okay, messages are coming, okay, okay. So don't worry, we will have a histology session also. Cartilaginous joint is synchondrosis. Primary cartilaginous joint is called as synchondrosis, okay. So this type of joints are mainly formed at the junction of, it is formed at the junction of epiphysis and that of diaphysis. It is found at the junction of, it is occurring at the junction of epiphysis and that of diaphysis, synchondrosis. So I told you the cartilaginous joint is the synchondrosis type. One example will be junction between epiphysis and that of diaphysis, which we have just I explained. Other example can be the junction. You have seen the base of the skull. There is a junction between basis sphenoid and basi-occiput. So the junction between basis sphenoid plus basi-occiput. This is another example of the synchondrosis. Also, first chondrosternal joint. First chondrosternal joint. This is an example of synchondrosis. Okay. Also, the other example is all the 11 pairs of ribs. All the 11 pairs of ribs. Which junction? The bony plus the cartilage. So the ribs are formed of, the ribs has got two parts. Okay, the rib has got a bony part and it has got an anterior end. You must have seen that ribs has got a cartilage. So the costochondral junction. So you can say costochondral junction. Okay, the costochondral junction of all the 11 ribs are an example of synchondrosis, and the junction of sternum and the first rib cartilage is an example of cartilaginous joint. Which type of cartilaginous joint? Primary. Please note down this point. Primary cartilaginous joint, not the secondary. So we have done with this. So I am moving to the next. So you can also tell me whether I am going fast or slow. Okay, you can tell me to ma'am please go slow, or you can go a bit faster. Okay. Now it is also important that we will go slightly faster. Why? Because we have to finish the entire thing, the basic and the crux point before your examinations. Now coming to symphysis. The other point is symphysis. The other type of joint is symphysis. It is called as secondary cartilaginous joint. It is which type of joint? It is secondary cartilaginous joint. It is secondary cartilaginous joint? Because in between the hyaline plate there is fibrocartilage. There is what? There is fibrocartilage. So in between the hyaline cartilage there is fibrocartilage, and this type of joint is an example of secondary cartilaginous joint. The other name of secondary cartilaginous joint is symphysis. It is symphysis. Okay. Now coming to the examples of, generally the midline joints are symphysis in our body. The midline joints, one example is IV disc. IV disc means intervertebral disc. Okay. Intervertebral disc. Let me see the messages. Okay. Intervertebral disc is there. Example. Other example is manubrosternal joint. Pubic symphysis. Pubic symphysis. Also symphysis menti. Symphysis menti. Okay. So these are the example of symphysis, secondary cartilaginous joint. See, basically the midline joints. Okay. Now coming to the most important joint, which is very movable, so many tons, very important for you. जब भी आपका viva होगा, when your viva start, they will ask you about the joints with an example. So the most mobile joint in our body is the synovial joint. So much mobility is there. Okay, synovial joint is the most mobile joint in our body, highly mobile, flexible. Okay, generally whenever you will see, when we will have a session of hip joint also, knee joint also, so generally these type of joint will have a fibrous capsule, it will have a articular capsule, it will have a synovial fluid inside. What is the role of synovial fluid? Providing lubrication to joint. It will give lubrication to joint. Okay, synovial fluid. So it is highly mobile joint, and when the synovial fluid degenerate, then the condition is called as osteoarthritis. When this synovial fluid is reduced, the lubrication is reduced, the joint will have friction. क्या होगा? Fluid is less, there will be more friction, and the joint surface will have a rubbing with each other, and that will cause a disease called osteoarthritis. So only in nowadays we are going for hip replacement, knee replacement. Okay, so this is the joint. So let's come to the joint. So we have got uniaxial, we have got biaxial, we have got polyaxial joint. We have got uniaxial, biaxial, polyaxial joint. So uniaxial joint, the movements are only in one plane. Movement occurs in two plane, or you can say 2 degrees of freedom. Polyaxial means more than 2, generally 3 degrees of freedom or joint mobility. Okay, the joint mobility occurs in 1 plane, 2 plane, or that of 3 planes. Okay. So plane joints, one basically starting with the first basic type of joint, then we will go into uniaxial. Plane joint में basically full to movement नहीं होता है, full comprise of movement, just the gliding. Plane joint में क्या होता है? सिर्फ gliding होता है, only gliding occurs. There is only gliding movement which is occurring place. And the example is, okay, so please just, I will highlight this diagram. So can you see, have you seen the vertebra? Okay, you have seen articular facets in the vertebra. There is articular facets in the vertebra. So as you can see, this arrow is showing the location of articular facets. This arrow is showing the location of the articular faces, and this joint is called as zygapophyseal joint. Zygapophyseal joint, which is an example of plane type of synovial joint. The joint which is between the articular part of the adjacent vertebrae, that is called as zygapophyseal joint, and this is an example of plane type of synovial joint. Okay, plane type of synovial joint. The other example is intercarpal and intertarsal joint. The joint between, okay, so this is an example. First, this is second and third. The joint which is between intercarpal and intertarsal, these are example of plane type of synovial joint. And one more example I want to give you is acromioclavicular joint. Acromioclavicular joint is again an example of plain type of synovial joint. Acromioclavicular joint is an example of plain type of synovial joint. Okay, done. Now moving to the next, hinge joint. Hinge joint, like movement in one plane. The movement occurs in one plane. Okay, like a hinge. The movement is in the form of hinge occurring in one plane. The example of these type of joint is, okay, so the movement is occurring in one plane, and the example of these, generally what happens, which type of movement is generally occurring in the hinge? Flexion and extension. The example is elbow joint. The example is ankle joint. Ankle joint. Example is flexion, extension, elbow joint, and that of ankle joint. Okay. Elbow joint, ankle joint, flexion and extension going on. That is an example here. Now coming to pivot joint, pivot type of joint. So in case of pivot joint, what happens? Main is rotational movement. Mainly which type of movement occurs? Rotational movement occurs. Okay, there is rotational movement occurs in only one, that is one type of joint is occurring. The example is superior radio-ulnar joint, or you can say radio-ulnar joint. Both are example of pivot type of joint, radio-ulnar joint. One more example is atlantoaxial joint. Atlantoaxial joint. Okay, atlantoaxial joint. This is another example which is also very important to know. It is important for you to know these all things, which is often asked as a question. So you should know that everything is important. So you can say, if you have seen, there is atlas and there is axis, there is a dens, okay, and there is an annular ring, there is a ring in which it moves. Okay, so that is an example here, pivot type of joint. Now coming to condyloid joint. Condyloid joint is an example of biaxial joint. These are example of biaxial joint. Okay, so for example, we take example of knee joint. Here the movement is not only flexion and extension, that is flexion and extension, but also along with flexion and extension, slight degree of rotation is possible. That type of rotation is called as conjunct rotation. So along with the prime movement, for example, condyloid joint example will be knee joint. So in the knee joint, the prime function is flexion extension, but along with that there is slight degree of rotational movement, conjoint rotation. So condyloid joint example will be knee joint, and along with it the other example will be TM joint. TM joint I am writing in short form. TM means temporomandibular joint. TM means temporomandibular joint. Now coming to ellipsoid joint. Next example is ellipsoid joint. Okay, ellipsoid joint, what happens? There is flexion, extension, and along with flexion and extension, there is slight degree of movement in antero-posterior axis, slight abduction, adduction. Okay, so the movement will be in the transverse axis and also in the AP axis. Okay, transverse axis and AP axis. Okay, so both means whenever I tell you it is, so again the ellipsoid joint is an example of biaxial joint. Okay, it is an example of biaxial joint, and wrist joint is an example of ellipsoid joint. Wrist joint, so this is the first example. Other example, if you want to write down, just write down. Atlanto-occipital joint. Atlanto-occipital joint. Atlanto-occipital joint is again example of ellipsoid joint. Very important. All these names which I am telling you, it is an important question for the Viva. They are going, if your examination is on the osteology also, they will ask you about this. They are going to ask you about these points. So it is important for you to know the example of each and every type of joint. So atlantoaxial joint is an example of ellipsoid joint. Other examples are, you just write more examples of this category, that is metacarpophalangeal joint. Metacarpophalangeal joint. Metatarso-phalangeal joint. Metatarso-phalangeal joint. Metatarso-phalangeal joint. So, 4 examples. Once more I will tell. Ellipsoid joint is an example of, wrist joint is an example of ellipsoid joint. Atlanto-occipital joint is an example of ellipsoid joint. Metacarpophalangeal joint and metatarso-phalangeal joint is again example of ellipsoid joint. So in this some books it is also written that these metacarpo and metatarso-phalangeal joint is an example of condyloid joint, but I will go for ellipsoid joint. Okay, so there is a confusion. Sometimes one or two joint in many books they will write other, but I will go for, I am in contest of ellipsoid joint. So more standard books will tell that they are example of ellipsoid joint. Okay, now coming to polyaxial joint. Polyaxial joint means the movement is so much, it is in the freely movable joints in the 3 planes. Okay, so the plane of movement will be in 3 plane. AP axis में movement होगा, ट्रांसवर्स एक्सिस में मूवमेंट होगा, वर्टिकल एक्सिस में होगा. ओके, सो वी हैव गॉट 3 planes, vertical axis, AP axis and transverse axis. So these type of joint are called as polyaxial joint and it is a highly mobile joint. For example, shoulder joint. Shoulder joint is a highly movable joint which is having glenohumeral joint. It is also called as glenohumeral joint which is quite movable. So it is again example of which joint? Polyaxial or multi-axial joint. Shoulder joint. Other examples, hip joint, ball and socket type of joint. So other example, this is shown here, this is hip joint. So other example will be ball and socket. There is a joint between the ear or cycles, that is also an example of polyaxial joint, that is incudostepedial joint. Incudostepedial joint. This is a joint between the ear or cycles, that is incus bones. This joint is between incus bone. This joint is between incus bone and that of stapes. That of stapes bone. Stapes bone is the smallest bone. So incus and stapes articulation is an example of ball and socket type of joint. It is an example of ball and socket type of joint. Okay. One more example, polyaxial. I just want to give you one other example. Just write down here only. I will write. Okay. Calcaneonavicular joint. Calcaneonavicular. Talocalcaneonavicular joint means the articulation between talus, calcaneum and navicular bone. This is a joint in the foot. The articulation between talus, calcaneonavicular joint is again an example of ball and socket type of joint. It is an example of ball and socket type of joint. Now saddle joint. My dear students, again students, friends, anything, because you are in the MBBS, so going to become the future doctors. So saddle joint, it is again an example of polyaxial joint. Polyaxial joint, it is again the plane of movement is 3. So the examples are following. So let's see the example. This example is first carpo-metacarpal joint. First carpo-metacarpal joint is an example of saddle joint. Also the sternoclavicular joint. Sternoclavicular joint is an example of saddle joint. Also incudomalleolar joint. Incudomalleolar joint is an example of saddle joint. Incudomalleolar joint is an example of saddle joint. Very important, all of this is asked in the examination, Viva. Now Hilton's law means the area which is supplied, the nerve, I will just explain, the nerve which supplies the joint, the nerve which is giving innervation to the joint will also supply the skin and the muscles surrounding the joint. The skin and the muscles surrounding the joint. Okay. So it is important for you to know the Hilton's law. Again important for Viva. All the points I will tell you which is important for the Viva. So if you are doing this point, all the questions will be answered. Okay. Hilton's law. Now coming to the muscles. So muscles, most important thing which is often as a viva question and also it can come as a long question is classification of muscles along to the morphological aspect or fascicular architecture. This is important for you to know the classification which is based on the morphological classification and fascicular architecture. Okay, that is here. I am showing you, this is a single diagram in which you can see the morphological aspect. It can either be a quadrilateral in shape. You can say it is, let me just highlight this type. Okay, see here. So here the shape is quadrilateral. Let me use some other color. Okay, so this here you are seeing it is quadrilateral in shape. It is either, it can be strap like as you are seeing. Okay, it can be either in the form of fusiform. Here it was strapped with tendinous intersection. What is this? Tendinous intersection. It can be fusiform digastric. It can be triform, tricipital. It can be triangular in shape as you can see in the diagram. Okay. It can be crisscross. It can be crossing from one end to other. So this type is called cruciate. See here. It can also be in the form of a unipinnate, means half of a feather. Okay. So these are unipinnate. It can be in the shape of a complete feather, then it is called as bipinnate. It can be circumpinnate, means all the pinnates are going and converging inside. This can be circumpinnate, or it can be multiple pinnate, multi-pinnate, so many feathers. As you can see, this is multi-pinnate. It can be spiral, twisted, as you can see in the diagram, it can be spiral and twisted. So many various shapes you have seen of the muscle fibers direction. That is important, and we will see a quick review of all these muscles. So starting with the parallel fasciculi. So in the case of parallel fasciculi, the pull of the muscle will be parallel to the line. This type of muscle will have wide range of movement. This will have wide range of movement. The muscles will have wide range of movement. Okay. But power will be comparatively less. Power will be comparatively less. What do you mean by the word comparatively less? Means parallel will be comparatively less than that of, convergent fibers, muscle fibers. So various example I will show you. So see this diagram. So here you are seeing this diagram in an example of quadrilateral muscle. So this, can you see the shape of the muscle? It is quadrilateral. So quadrilateral muscle fibers. Quadrilateral example is thyrohyoid, pronator quadratus. This is a muscle which you must have seen in the dissection of the upper limb. Here we have got, here at this level, at the lower end of the radius and ulna, we have got on the flexor aspect here, we have got which muscle? Pronator quadratus. So these are example of quadrilateral muscles. See the green color muscle I have highlighted. This is which type of muscle? Like a belt. So this is an example of like a belt. This is an example of strap muscle. Strap muscle. The example is sartorius muscle. Sartorius muscle, as you know, sartorius muscle is a muscle which is lying in the, sartorius muscle is a long muscle, as you can see, anterior aspect of the thigh. Sartorius muscle is an example of strap muscle. Now see here, dear friends, you can see the muscle shown in the diagram is again an example of strap muscle which is having a tendinous intersections. Can you see? The muscles is having tendinous intersections. So strap muscle with tendinous intersections, These are the example of these type of muscles. Example will be rectus abdominis muscle. Rectus abdominis muscle. So dear friends, rectus abdominis muscle, the six-pack muscle. All of the girls and the boys, they have got a craze of having full toned muscles. Okay. Sabko kya banana hai? Six-pack muscle. So six-pack muscle is, example is rectus abdominis. Okay. Okay. No one wants to make a bulky pack muscle. Okay. One pack muscle. No one wants. Yeah. Now coming to fusiform muscles. Example, fusiform muscles. biceps, you can say. You can see the shape is like a fusiform, bulky in the middle. Example is biceps brachii as shown in the diagram. Also there will be another example with fusi which mein hota hai, that is digastric muscles. Digastric muscles. So these are very easy, but what happens at times when the Viva question comes to you, you are not able to reply because it gets intermingled. So keep on practicing these points. These are very important and often favorite choice of the questions that come from the different colleges. They will come. They will ask you, आपका exam होगा gross anatomy का, but they will ask you general anatomy. Okay. The other is spiral and twisted. See here. So can you see the muscle on the posterior aspect? This is which muscle which is spiral and twisted? Latissimus dorsi muscle. This is latissimus dorsi muscle. Another spiral and twisted muscle on the anterior aspect. Can you see this? This is pectoralis major muscle. So these are all examples of spiral and twisted muscle fibers. So you can see another example, same muscle which is shown also. This is the LD. LD means latissimus dorsi muscle. Cruciate fasciculus, can you appreciate this muscle? Both the side it will have. This muscle is SCM, sternocleidomastoid muscle. Sternocleidomastoid muscle, the muscle which is lying on the lateral aspect of the neck, dividing the neck into two triangles, anterior triangle and that of posterior triangle. Example is sternocleidomastoid muscle, cruciate muscle. Another example which I am showing you in the diagram, can you see this? This muscle is masseter muscle. Masseter muscle, it's a quadrangular muscle. Just clench your teeth and just feel it, the masseter muscle. Okay. Now, these are another examples altogether muscle. Most of it we have done. Can you see some muscles have circular or sphincteric fasciculi? Sphincteric fasciculi. So example of these type of muscle which is having circular or sphincteric fasciculi is orbicularis oculi and orbicularis oris. Orbicularis oculi and orbicularis oris is example of sphincteric fasciculi. Also, I just want to show you in this diagram pinnets. Okay, so just see here. So this is a muscle which is unipinnet. This muscle is bipinnet. This is showing the muscle which is multiple pinnet. Okay, multiple pinnet as shown here. So example, unipinnet examples are, write on unipinnet example is palmar introsiosi muscle. Palmar introsiosi muscle, first and second lumbrical muscle, first and second lumbrical muscle. Also FPL is an example of unipinnet. FPL means flexor pollicis longus. Coming to the example of bipinnet. Bipinnet example is dorsal introsiosi muscle. Dorsal introsiosi muscle. Also, okay. So dorsal introsiosi muscle is there, which is an example of bipinnet. Okay. This is the example of bipinnet. So other example is third and fourth lumbricals. Third and fourth lumbricals, which is an example of bipinnet. Also other muscles which is an example of bipinnet is rectus femoris muscle. Which muscle? Rectus femoris muscle. You can see this is the muscle which is lying here on the anterior aspect of the thigh, that is rectus femoris muscle. Rectus femoris muscle is an example of bipinnet muscle. Is an example of bipinnet muscle. It is an example of bipinnet muscle. So I will once more open this. Let me see why it is hanging. Okay, it's okay. Now it is okay, no? Yeah. So we have seen the example of unipinnate, bipinnate. Now coming to the example of multipinnate and that of circumpinnate. Coming to the example of multipinnate and that of circumpinnate. Okay. So write down circumpinnate. Circumpinnate muscles example. Tibialis anterior muscle. Which muscle? Tibialis anterior muscle is an example of circumpinnate muscle. Tibialis anterior. Multipinnate. Multipinnate. This is an example. The example of muscle is deltoid. To be more specific, which fibers of deltoid? Acromial fibers of deltoid. Which fibers? Acromial fibers of deltoid is an example of multipinnate. Okay. Now coming to the muscles action, the classification of muscles action according to that, prime movers. Prime movers like this, I am flexing my, for example, I am taking the example of upper limb flexion. So when I am flexing, the prime muscle which is causing flexion of elbow is biceps brachii and brachialis. So these becomes the example of agonist muscle of prime movers. They are also called as agonist muscle of prime movers. Coming to the muscles which is having action just opposite to agonist. So when I am telling that biceps brachii is agonist muscle, what will be the antagonist muscle? Means the muscles which is causing the extension of elbow joint. So the muscle will be triceps. So antagonist muscle will be triceps. Now see here. Now what happens, for example, if I will tell you the example of abduction. Okay, so let me just big it. Now abduction means above the shoulder joint. So I am combing my hairs like this. If I comb my hairs like this, so this movement is abduction. So for abduction to occur, what happens? The scapula and this head of humerus is moving upward. So something should be there which is connecting the medial aspect of scapula with that towards the vertebral column. So when the movement of abduction occurs, the muscles which is connecting it to the medial aspect of vertebral column, that is rhomboides major. If you remember, these rhomboides major and that of rhomboides minor are the muscle which is attached to the medial border of scapula to that of vertebral column. Okay, to the I will take a session on the muscles in where I will explain each and every muscle's origin, insertion, action and of supply. So rhomboides major and rhomboides minor is acting as a fixator muscle. Fixator muscle when the deltoid muscle is causing abduction. When the deltoid muscle is causing abduction, these muscles, rhomboides major and minor, is acting as fixator muscle. Now, the next category of the muscle which I want to explain is synergist muscle. Which is the muscle? Synergist muscle. Okay. Now, what happens? For example, I tell you to flex the fingers. Please understand, these are basic points. I am telling you to flex. I am flexing my fingers. Can you see? I am flexing my interphalangeal joint. So, if I am flexing my interphalangeal joints, I am not flexing my wrist. What is this movement? This is wrist flexion. No, this is extension. This is flexion. This is extension. Okay. So, I am able to flex my fingers. But if you remember, for example, flexor digitorum profundus muscle. Okay. So, these muscles are flexors of the wrist and they are also flexors of the phalanx. They are also causing flexion of interphalangeal joint, but they can also cause flexion of the wrist. So, but when we want the flexion only to take place at the distal joint, that is interphalangeal joint. Okay, so we don't want that the wrist is flexed. So at that time, the extensor muscles act as synergist muscle. So when I am telling flex the fingers, which muscle is acting as a synergist? Extensor group of muscles. Extensor group of muscles is acting as synergist muscle. After that, coming to the muscles classification according to the force of action. So we have got two muscles. One is called as shunt muscle, other is called as Sprute muscle. Again, you understand this. Okay. So again, I am taking the example of flexion of elbow joint. Example is flexion of elbow joint. So when I want the flexion to take place, so Sprute muscle is also called as swing muscle. Swing muscle. So the biceps brachii biceps brachii and that of brachialis muscle is the example of swing muscle which is causing more of rotational movement. At the same time, there is another muscle that is brachioradialis. I have also got a brachioradialis muscle, and this brachioradialis muscle becomes an example of shunt muscle. Okay, so the role of shunt muscle is to stabilize the joint. So how you remember? Shunt muscle is causing stabilization of the joint. It is not involved primarily action of the flexion. It is acting as a supporting component. The prime function of flexion is done by biceps brachii and brachialis. So they are example of swing or rotational movement. This is also called as sprute muscles. So another basic point I just want to tell you about these muscles, that if you will see here, the prime movement is flexion. Flexion is occurring at which joint? Elbow joint. Flexion is occurring at elbow joint. So the sprute muscle, which is also called swing muscle, the origin will be away from the joint, and the insertion of sprute muscle will be towards the joint, If I will take the example of shunt muscle, the shunt muscle origin will be close to the joint and insertion will be away from the joint, Okay? Shunt and sprute. Have you understand, or I repeat? All of you. This is the basic point which has to be understand. All of you reply once more, or is it okay? Shunt and sprute. So here the sprute muscle, shunt muscle. So here the sprute muscle is biceps muscle. For example, biceps muscle. So biceps muscle originates from coracoid process and that of supraglenoid tubercle. So the elbow joint से उसका origin कहाँ है? Distance. It has got distance from origin point. So that is correct. Insertion is occurring on radial tuberosity. That is close to the joint. For example, brachioradialis is acting as a shunt muscle. So where is the origin? What I told you, origin will be close to the joint. See this point? What I told you, origin will be close to the joint. So brachioradialis is originating from supracondylar ridge. So it is closed, but insertion is away from the joint. So brachioradialis is inserting on stelloid process of the radius. So it is away. Okay, why? Okay, no, yes, ma'am, it is difficult. Okay, that is previous only. Sprute and shunt. Okay, so just in one line I will explain you sprute and shunt. Shunt is stabilizing muscle. Sprute muscle is the primary actor. So if biceps brachii is swing or that of sprute muscle, its origin will be away, but insertion will be close to the primary joint, that is elbow joint. For example, here in the primary action of flexion, brachioradialis muscle is shunt muscle. So their origin will be close to the joint, but insertion will be away from the joint. Okay. So now coming to the list of hybrid muscles. So this is very important. This is often asked in the MCQs. So I will just brief you about some of the hybrid muscle. What do you mean by the hybrid muscle? This is a favorite questions of the examiners. They have got dual nerve supply. These type of muscles have got dual nerve supply. So they are also called as composite muscle. These type of muscles are also called as composite muscle. Examples are, write down. Hybrid muscle example is brachialis muscle having nerve supply both radial nerve and musculocutaneous nerve. Example, trapezius muscle. Trapezius muscle is both supplied by spinal accessory and that of C3 and C4 nerves. Coming to the other list, same is the sternocleidomastoid muscle, both spinal accessory nerve and that of C3 and C4. Okay. Coming to the other list, FDP means flexor digitorum profundus. Flexor digitorum profundus. This is again having both nerve supply, that is median nerve and that of ulnar nerve. Again example of median nerve and ulnar nerve. FDP, flexor digitorum profundus, again an example of hybrid muscle having dual nerve supply, both median nerve and ulnar nerve. Other example will be flexor pollicis brevis. Flexor pollicis brevis again has a nerve supply, median nerve and that of ulnar nerve. Other examples will be flexor pollicis brevis we have done. Now coming to the other examples of the composite or the hybrid muscle. You have to know the list, which is often asked as a viva examination. So coming to this list, adductor magnus. Adductor magnus has got again dual nerve supply, obturator nerve and that of one more nerve is there, that is tibial component of sciatic nerve. Tibial component of sciatic nerve. Again, I want to tell you the other list. Please have the list. Most important, I will tell you all. Digastric muscle. Digastric muscle. Anterior belly and posterior belly. Posterior belly by facial nerve. Anterior belly by trigeminal. Which part of trigeminal? Mandibular. Okay, so trigeminal, fifth nerve. Other example will be, you can know there is short head and long head of biceps femoris. So biceps femoris, you can take the example of biceps femoris, short head and long head. So long head by tibial component of sciatic nerve. Short head by common peroneal nerve. Common peroneal nerve. Okay, common peroneal nerve. Other example, pectineus muscle. Pectineus muscle is supplied both by femoral nerve and also by obturator nerve. Okay, so many list is there. You have to know all of it. And also when I will take the individual muscle class, I will also explain once more the list. Okay, so I think this is today I have finished all the important topics. I have detailed every point of muscles, joints, all the important points which is often asked as in viva examination and the theory examination. So all the best to all my students. Okay, do well in the examination. So it is important for you to know all these basic points. Okay, so I am ending the session. I have done with the session. So tomorrow we will again start with the new topic. Okay, I will start with the slight important topics of, we will start with the general embryology part, important topics on the general embryology part, and then we will cover it in the next class, the whole of it. I will start with the basic concepts which you should know. So done with this. All of you have done with this. Now coming to the tomorrow's session will be again on the 8 p.m. All the best. Keep studying. Don't worry. Everything is also given. Details are there in the book. All the basic point, what is asked in the examination, what is competency required, what you have not to leave. I will tell you all that points, both for examination and the theory papers. Thank you. So I am just ending this session. Thank you all of you. You can write, you can text me your doubts. So we will again have the session tomorrow. Okay, all the best. Okay, synergist muscle. Okay, he is asking me. Okay, I will just take one synergist muscle and then I will close the session. Yeah. Coming to the synergist muscle, I will show you the diagram once more, then you will understand. Yeah, see here. So synergist muscle, you want to understand synergist muscle. So I will tell you. For example, FDP. What do you mean by FDP? Flexor digitorum profundus. Here you can see there is a muscle that is FDP, flexor digitorum profundus. So if I tell you to flex the fingers, can you flex it? This is finger flexion. This is flexion of the phalanx. So we can do the flexion of phalanx, we can do it. But at the same time, as we have got, okay, just let me see. Okay. Okay, Nitesh, yeah, thank you so much. Okay, synergist muscle, general. Okay. Basically, all that books that is Langman's and Student's Anatomy, Gray's Student Anatomy. I'm not telling you the main Gray's Anatomy. So you can go for Langman's Embryology. You can go, and you can go for Last Anatomy. You can go for Grant's Anatomy. You can go for Last Anatomy, Grant's Anatomy. These are the basics book which start with the general anatomy, and all the basic points I have completed, but somebody has a doubt in the synergist, so just listen. Okay, this is my fingers. I want you to flex the fingers. This is phalanx. You can do it. Okay, the muscle which is responsible for flexing the distal phalanx is also crossing the wrist. Okay, when we want to flex the fingers, the muscle can also flex the wrist. What is this? This is flexion of wrist. This is extension of wrist. This is flexion. This is extension. Okay. But if I tell you only flex your fingers, distal phalanx, if I specifically tell you only flex your distal phalanx, you can do. At the same time, there can be flexion of the wrist also, but this is not done by the action of extensor muscles on the opposite side. So extensor muscle is keeping our wrist straight. So when I tell you to flex the fingers, we can tell that the muscle which is opposing this action of flexion at the wrist is acting as synergist muscle, means helping to do the flexion at the fingers, helping to do the flexion at the fingers or distal phalanx. Okay. So done with today's session. We will meet tomorrow. Okay. Thank you, everyone. Okay. Thank you. I am ending the session. Thank you.